in primary care, especially in the younger set, but not that unusual in older adults as well. And of course, we have a few different alphabet soup ingredients here for earaches that we want to take a look at in this lesson. AOM, acute otitis media, refers to bacterial infection behind the tympanic membrane, or as I like to tell my pediatric patients, there's a pus party in your eardrum, and that's what makes that earache occur. You'll be hearing more of that from the student presentation. Otitis media with effusion, or OME, is a little bit confusing because it sounds a lot like acute otitis media, and many people use the term otitis media with neither the acute before or the effusion after to describe bacterial acute otitis media. So you do have to kind of be careful about that. But technically speaking, otitis media with effusion is a different problem, and it pertains to fluid that has been trapped behind the eardrum or the tympanic membrane because of its inability to drain, which it normally would, through the eustachian tube into the posterior pharynx. Again, a great case for really revisiting your anatomy and physiology materials to understand that this is a normal occurrence. So again, we see this in all ages, a lot in children, where the eustachian tube is very small. In older children and adults, sometimes that eustachian tube has become scarred either by repeated infections or exposure to smoke, either tobacco or other smokes. And that scarring creates a narrower lumen in the eustachian tube, and thus it cannot drain. And the pain of otitis media with effusion is a milder pain, more chronic, and rarely develops into a pain that needs any particular attention. It worsens when the patient has a cold, and sometimes there is a history of viral infection that has precipitated the awareness of the effusion. And the third otitis is otitis externa. And this is classically known as swimmer's ear, but it is actually a soft tissue infection of the ear canal and does not affect the tympanic membrane. Now, can all three of these exist in the same patient? Absolutely. We see patients who have chronic otitis media with effusion who may develop a bacterial acute otitis media. Those persons can also develop otitis externa from a variety of causes, and we sometimes see the otitis media, acute otitis media, the bacterial type, causing a perforation of the tympanic membrane and the exudate flowing out through the canal, irritating the canal, creating a localized infection as well. And the patient kind of has both things going on, and you'll see exudate that may or may not represent the pus from inside of the tympanic membrane, or it's the exudate from otitis media, otitis externa, or swimmer's ear as it is commonly called, although it is not necessarily caused from swimming. So let's take a look at one case of earache. This is a 67-year-old male who presents to urgent care in the ED with a chief complaint of left earache. Pain has been persistent and worsening times 2 weeks. He notices a yellow-white exudate coming from the left ear. His past medical history is significant for chronic obstructive pulmonary disease, treated with multiple inhalers. He uses oxygen as needed. He's retired, stopped smoking about 4 months ago, and he's now enrolled in the swimming program at the Y for pulmonary rehab and to help him stay off cigarettes and keep his weight down. So as we discussed before, one approach here is to kind of walk in the room, if you will, with a set of differential diagnoses in our head. And again, trying to divvy up that information into information that seems to support our idea of our working diagnosis and those that refute that or our set of differentials and the common differentials in this situation. So he's got ear pain, and it isn't particularly acute, but today it's gotten worse, so he's seeking care. And he certainly has some information in his history that supports the diagnosis of otitis externa. His ear has been wet and not probably been dried properly, and that is, of course, one of the precursors to otitis externa, that moist environment inside the ear that is not normal in everyday life. And he has possibly some irritation even from the chemicals of the pool, which can cause drying, further drying of the ear canal, as the book talked about, and set him up for otitis externa. There are some other questions that I always kind of check in with patients about, who, especially folks who might not have as dramatic a history. I do ask them about any objects that they put in their ears. Things like Q-tips, which seem to be harmless and soft, may actually cause trauma to the ear canal and actually break off the microscopic hairs that drain the ear wax. If a patient is vigorously removing wax from their ear, they're removing a protective layer on that skin. If a patient has a history of psoriasis or other skin conditions that might affect the ear canal, that again sets them up for that microscopic lesions that can open the door for bacteria to get inside that ear canal and infect the skin of the ear canal. Hearing aids are another possible situation, especially in an older adult. I kind of think of that and wonder if they've been wearing their hearing aids and if those are creating, again, that kind of moist environment. So lots of things go through our heads as we think of, here's the usual situation based on his history. He's been in a pool, and likely that's our first working diagnosis. However, he's told you about an exudate coming out of his ear. So we do have to think of, does he have a concurrent otitis media that has, acute otitis media that has created a perforation in his eardrum? Or if he's a little tyke, we always kind of ask the question about their history of possibly having ventilation tubes in place. Those little tubes that kids get in their ears who have chronic ear infections and chronic otitis media with effusion or fluid behind the eardrums. Those tubes are put in place to create a hole, to create basically a perforation of the TM, and is that exudate draining from inside of the eardrum. So that's a possibility on our list, that does have an acute otitis media, concurrent or not concurrent, just causing his pain. The otitis media with effusion, not particularly a diagnosis of exclusion here, because he really does have some pain, and the exudate is different than what we would see in that case. Now, don't miss diagnoses with ear pain. Really have to do with the spreading of the infection into other tissues of the head and cranium, and a malignant otitis, or and there are conditions where there's an infection of the bone, mastoiditis, that we certainly don't want to miss, and those may be more evident on exam than by history. But in his history, there are a few red flags here, even though he doesn't use oral steroids at this time. He is on a lot of medications. He's got chronic illness. He's older, and he's a little bit of a setup for a person with a compromised immune system, and certainly has that potential. And we are worried about that because of the possibility of, again, the spread of this infection. You know, there are some zebras to think about when an older guy comes in and says, boy, I have ear pain or jaw pain. And those have more to do with referred pain from cardiac sources and so forth. But really, our question set could clear that up fairly quickly. He's been having this for a couple of weeks. It's gotten worse. He's got drainage. So unlikely to be referred pain. But I do throw that in because those will be the kinds of things that as you get more advanced in your thinking, you will want to quickly rule out just by understanding the history of what's going on. So in addition to this funky looking ear canal, which has got some creamy white exudate, is very narrow, looks swollen, tender, and so forth, you're going to find that on exam, unlike otitis media, acute otitis media or otitis media with effusion, this kind of ear problem, when you touch the patient's outer ear, particularly the pinna, you are going to, in the trachea, you are going to elicit quite a bit of discomfort. They're really going to be uncomfortable with you touching any part of their ear. I will confess that I can't say that I have ever instilled anesthetic drops in order to make that exam easier for either adult or child. I'm always worried about a perforated eardrum, especially when I see exudate. So until I get a closer look, I'm just really careful and cautious and try to not manipulate the outer ear very much. But that's kind of a tip-off, the outer ear tenderness, that you're going to be looking at an otitis externa infection. I always, of course, I'm very systematic with my exam, and you could, of course, inspect and then palpate in not only the ear structures, but you want to palpate for any preauricular node enlargement, any mastoid tenderness, which is telling you a whole different story. I really want to satisfy myself that that is not the case. The other little trick is I always try to use a pediatric ear speculum so that I can look in and see that tympanic membrane, because I really want to know what its condition is before I make a decision on the course of treatment, especially in terms of topical treatments. Here's a picture of what that ear canal often looks like. It's kind of got this soft yellow whitish exudate that can be scraped away or pulled away with one of those ear loops. And there's just a very narrowing of the ear canal through which you can usually pass a pediatric speculum. Sometimes you cannot. Again, if you don't know, you're just going to play it safe and be careful about the exudate. But generally speaking, there is just that exquisite tenderness, swelling, the redness, and this exudate coming out that gives you the classic signs of otitis externa. In his case, you might argue that he might need systemic treatment, but he's not, technically speaking, immunocompromised at this time, and the likelihood is that in most cases we can see improvement of the externa with topical treatment. It's best to be sure to use a drop that is not going to irritate the inner ear if you suspect in any way a tympanic membrane rupture, or if there are ventilation tubes in place in the case of a child. So there are a couple of formulations that are okay to put in the inner ear, and you look in your book